I'm Alan Moses. I'm the inventor of the Moses Express sleep apnea snoring device. And I'm going to show you how to make one, how to collaborate with your laboratory to make one, and why we're doing it the way we're doing it. One of the prime, most important uh, parts of this, the uniqueness of the appliance, is the position in which we record the relationship between the maxilla and the mandible. We can call it a bite, but this bite has nothing to do with teeth. This bite has to do with the position of the maxilla related to the mandible. So, most important function of the back and neck is to support the head in the upright posture. And we do this bite standing up for that reason. What we're looking for is to find the position of the largest airway possible. The largest airway is achieved in a position of, we'll say, fight or flight, autonomic nervous system, sympathetic dominance. So all of a sudden, there's something very fearful that you have to respond to. So let's say there's a tiger that comes around the corner, and you see that tiger wants to eat you for lunch. You have to either run or fight it. And so that's the position that we want to achieve. In that position, you have to have the biggest airway. The biggest airway so you can breathe better if you're running or fighting. And so we have a way of capturing that position. It's based on manual muscle testing, and that's what we will demonstrate. When we look at the pictures on the poster here, this is an airway. This is the larynx, the pharynx, and the larynx. These are the nasal sinuses, and this is the nasopharynx. And this is rest position. In rest position, lips together, teeth apart, tongue in the roof of the mouth. This appliance, this one, the one on the right, the appliance is in place. The appliance, same structures in the top, airway. But you can easily see that the airway is dilated in 3 dimensions. And so what we want to do is to have the patient stented open in the position of optimal oral airway dilation at night, because that will make it easier to breathe. Okay, to do this, we're going to use the Moses bite stick to find the best maxillomandibular relationship. In this device here has 9 arbitrary jaw positions. 300 is 3 vertical, which is vertical up and down, and 3 and 0 protrusive. So that protrusive is edge to edge. There's no protrusion if the jaws are upper, over, lower directly. Then the next one is 3015. In 3015, we have 3 vertical and 1.5 protrusive. The mandible is protruding 1.5 millimeters. The next one is 3030, 3 vertical and 3 protrusive. And that's exactly more protrusive. And it goes on. So we have 400, 4015, 1.5 protrusive, 4 vertical. And then we have 4030, 4 vertical, 3 protrusive, and last the 5 level. So we have 3 levels that you could do vertical dimension, 3, 4, and 5, and we have 0, 1.5, and 3 for protrusive. And so what we want to do is find the optimal position. Optimal position is based on, let's say, why we do this in this position. An analogy would be that the human being is a computer. So you buy a brand new computer, and that computer is lightning fast. And so that's called the equivalent of facilitated. Then you use your computer a long time, and it slows down. And so at that point, you get ready to buy a new one. It's loaded with clutter. And so we have a computer, and that computer constitutes the hardware. And then we have software as human beings. The software is, hey, you're born and you know how to swallow, and you know how to breathe, and then at some point you learn how to walk, and this is software that's being trained. Now, if you have a computer and you have hardware and you have software and you turn it on, nothing's going to happen. because in the computers that we have today, you need an operating system. And so in effect, analogous, and by virtue of analogy, I think what we are doing is we're using this technique to fine-tune the operating system to the point of optimal neurologic facilitation. It sounds complicated, so we'll demonstrate. So, the dentist takes an upper impression, the dentist takes a lower impression, sends to the laboratory, and the bite using the bite stick. What the laboratory will send back to you is an upper retainer, a lower retainer, and the formed appliance. It's as simple as telling the patient, put the upper in place, put the lower in place. You insert this for the patient. This is inserted in the patient's mouth, and if there's no sore spots, you're done. That's it. Very, very simple. 5 to 10 minute insertion procedure, delivery procedure. The laboratory will take the bite that comes to them and mount the case on an articulator. We have a very deluxe articulator here. The laboratory will mount the case on the articulator, and then the laboratory will mount the case on an articulator, and then the laboratory will make the upper, the lower, and then the laboratory will take the bite. No, the case is mounted. They take the blue material that comes as it comes in the package, heat it in 170 to 180 degree water, put the soft material on the model, form it a little bit first, position it, close the model, and then form it inside, outside, and then form it on the inside. The laboratory sends the case back to the dentist, and what is sent is upper, lower trays, retainers, and the appliance itself.